Since everyone got quiet, I thought it would be a good time to start. Good afternoon. My name is Michael Erickson. I'm the Dean of the School of Public Health at Georgia State University, and I'm proud to host the fourth annual Kreuter Katz Lecture today. This is a very special signature event for us at Georgia State, and as I said, the fourth lecture. We'll tell you a little bit more about the details in a second. But this lecture series was established to honor the accomplishments and the continuing efforts of Martha Katz and Marshall Kreuter, who are sitting here in the first row. If we can give them a round of applause. I won't say more about their accomplishments because you have a pre-read material here that you can all look at to read about Marshall and Martha and what they've done in their career and the establishment of the lecture series in their honor. And those of you who don't know Marshall and Martha may be confused over the title of today's presentation, saying, well, I thought his name was Marshall Kreuter, not Matthew Kreuter. It says, well, there's a Matthew Kreuter, too, that we'll be introducing shortly, who will be giving the lecture. So it's a family affair. We're very delighted to be able to bring together scholars and families and individuals who are making a difference in people's lives throughout the United States and around the world. This lecture series is supported by the Healthcare Georgia Foundation. Gary Nelson, who will introduce Matthew in a minute, through his vision of dedicating resources to honor and acknowledge the contribution of people who make a difference in other people's lives. All too often, the hard work that's done to help others goes unrecognized. And this is one of those rare opportunities where we have a chance of honoring and acknowledging the contributions of others who are making a difference, and also to learn about the cutting-edge work that's going on around health equities and trying to assure health equity at a particularly important time in our history. We're very proud. This is the first Kreuter Katz Lecture that we've hosted as being an accredited School of Public Health. We received our full accreditation in June of last year. We're very proud of that. It's not something you do overnight. I can say it's a process that takes years, if not longer, to successfully navigate that. And we did navigate it in a very special way with very few concerns, and we feel really represents the hard work of all of the staff and faculty and students who have been a part of the Georgia State story for the last 10 or 12 years. It's amazing what's happened over time. We have over 600 alumni now, and I can very vividly remember our first graduating class that Gary hosted a cake and coffee for, and there were 4 students in the Healthcare Georgia Foundation office, and we were just so proud that we had actual 4 graduates. And to think that over the 10 years since then, there are now 600 graduates who are working throughout Atlanta, Georgia, the United States, and around the world. And we're extraordinarily proud of our alumni, and I believe that they are also very proud of their university and what Georgia State's done for them. So it's a very special dynamic. I feel honored to have been able to be part of it. Our newest part, as we're going forward, is this academic year, we started an undergraduate program, and we have 150 Georgia State undergraduates who've expressed interest in public health as a major. And I'd like them to stand in the back of the room so people can recognize you. Come on, don't be shy, come on. So over the years, we've spanned from a graduate program only with an MPH and a PhD to a beginning and an undergraduate program, of which we're very proud. Before I introduce Gary to get the program underway, I would just like to mention 2 other things I think are important as you come together at Georgia State to learn more about our public health program. And this is the College of Law building, a spectacular building on Peachtree, all glass, that represents the transformation of how universities and cities interact. If you look at the building we're in, the Urban Life building, it looks like a castle with turrets, built in the 80s, where we could shoot our arrows out the windows, but wasn't a lot of interaction and transparency between the city and the university. And today, a building like this that just stands at the foot of Peachtree, next to Georgia Pacific, major Fortune 500 companies, is a testament to the integration of the university and the city. One of the two things I'd just like to mention as little snippets to give you an idea of our program and the pride that we have in it. Last week, the university initiated a new program. It was for graduate students. It's called the 3-minute thesis. I don't know if anyone's ever heard of it or not, but it started in Australia, and it was a program to get students to present their thesis or dissertation in 3 minutes with one slide, no animation, and they had to stand up in front of an auditorium and present their information. And there was a competition at Georgia State, and in that competition there were 12 finalists, 6 master's students and 6 PhD students. And of the 6 master's students, and you have to understand Georgia State's a university of 50,000 now with Perimeter College. With the 6 graduate students who are the finalists, 2 of them were MPH students, 2 of 6, and of the PhD students, 1 of them was a public health student. So we were very proud to have our students represented there, and particularly proud to announce that the winner of the master's, PhD, or master's 3-minute thesis is Brittany Carter. Brittany, would you stand up, please? I came away from that presentation with the understanding that this skill set of presenting a thesis in 3 minutes is a skill set that faculty should have as well. So I'm going to encourage, and myself, encourage all of us to learn some of the skills about being succinct, standing in front of a crowd, and getting your point across, all of which is to say, I'm done. Gary Nelson, come to the podium. Gary will introduce our speaker. Gary's the president and the founder, really, of the Healthcare Georgia Foundation. Gary, thanks. Sure.
3 minutes? 3 minutes. 3 minutes. Thank you, Dean Erickson. And before I introduce our guest, I want to commend you and the administration, the faculty, staff, students, and alumni for what you have collectively accomplished in building this terrific School of Public Health. Performance has been amazing over these few years and your short history. So welcome to the 4th annual Kreuter Katz Lecture on Health Equity, a lectureship focused on health disparities that honors the careers and distinguished contributions of Marshall Kreuter and Martha Katz. As you may know, this lectureship previously featured the research and thought leadership of Dr. Kawachi from Harvard, Dr. Jim Marks from the Robert Wood Johnson Foundation, and Dr. Helene Gale from CARE International. Today's lecture brings to us a unique and often overlooked perspective on health disparities, and that is the role of health communications. Dr. Matthew Kreuter, by the way, the last name is more than a coincidence, had no choice in being the lifelong recipient of public health communications from Marshall and Martha. As you will see, the public health community has benefited terrifically from this relationship. Matthew is a leading national public health expert in the field of health communications. He joined the Brown School at Washington University in St. Louis in 2008 and advances the school's Master of Public Health degree as a Kahn Family Professor and Associate Dean for Public Health. He currently serves as a member of the Faculty Advisory Council of the Institute for Public Health at Washington University, and he holds a secondary appointment at Washington University School of Medicine. As a founder and senior scientist of the Health Communications Research Laboratory, and I think your brochure says 22 years of continuous funding, something like that? Yeah. Dr. Kreuter has developed and evaluated a wide range of health communication programs to promote health, modify behavior, and prevent and manage disease. Building on his interest in social marketing, his book, Tailoring Health Messages, is the first comprehensive book focused on health communications. Dr. Kreuter currently serves on the Institute of Medicine's Board on Population Health and Public Health Practice. Other funders of his work include the National Institute for Child Health and Human Development, the National Institute of Nursing Research, the U.S. Centers for Disease Control and Prevention, the Office of Disease Prevention and Health Promotion, and the Susan G. Komen Breast Cancer Foundation. By the way, Matt is joined today by his equally professionally gifted wife, Shar, and his two sons, Cal and Will. It has been written that Dr. Kreuter has a single-minded determination to translate scientific discoveries and knowledge into accessible, on-the-ground health services for high-disparity populations. His passion for the work, coupled with his creativity, is evident in his research, and you'll have to ask him about kiosks and laundromats, or in teaching and immersion learning opportunities he provides for his public health students. So with that 3-minute introduction, please join me in welcoming the 2017 Distinguished Kreuter Katz Lecture, Dr. Matthew Kreuter.
So the year is 1993. I'm a brand new PhD graduate, and I've just given a talk at a professional meeting, and I'm walking out of the room, and a woman stops me, and she says, "I just want you to know that I really resent you." Back up. "How old were you," she continued, "when you wrote the Precede Proceed book?" Which is a book that my father and Larry Green wrote. And so I explained to her, I said, "I was 16, why?" Do you ask? So it has been a great honor for me and enormously beneficial to carry the Kreuter name through a career in public health. Gary, thank you very much for your kind words in that introduction. Michael, thank you very much for considering me as this year's speaker. It's a privilege and an honor for me to be here to recognize the great work of Martha Katz and Marshall, is it Kreuter? Am I saying that right, Kreuter? With this year's lecture on health equity. Where'd my clicker go? Here we go. So my dad and I go way back. This demonstrates that I've known my dad for a long time. And Martha and I met later, but bonded immediately, I think, over not just a love of my father, but also a real fondness for very stylish sunglasses. Mine are pink, so much so that I was invited to their wedding. And what has not changed over all of those years is Marshall and Martha's commitment to health equity. So I want to share with you a news article that goes back to 1973. And I was 10 years old at the time, and my dad had developed a pretty remarkable project. And this news story describes how each year he would enroll community members into a summer course, many of them elected officials, members of the state legislature. And as part of the course, he would take away all of their personal belongings except for the clothes on their back. So no car, no purse, no wallet, no money, no ID. And he'd give them each 20 cents, 2 dimes. And they had to live on the streets for 3 days and 3 nights. And they learned quickly and very personally what it's like to be poor for 3 days, what it's like to work serving the poor, and the resource constraints of helping agencies. And the project won awards and I think influenced some of those policy makers. And I think the spirit of that work 45 years ago has continued and continued through a career that involved work at state and federal public health agencies and in communities from everywhere, including the Navajo Reservation to low-income neighborhoods here in Atlanta. So everybody here has parents. Not everybody gets a chance to publicly thank their parents for a lifetime of love and support. I'm not going to miss my chance today. So I mentioned before that Precede Proceed book that my dad and Larry wrote. This is actually the very first edition. Recognize it? And this particular one is the one that my father signed and gave to his mother. So I've got the inscription here, and I want to read this to you. This is my dad writing to his mom. Dearest Mom, your son Matthew is amazing. No, it doesn't. It doesn't say that. But it does say, this book will not read like Gone with the Wind, but it's a project I'm proud of. Please know that the accomplishment and any others I might make are due in large part to your support and encouragement. My desire to do well and drive to complete tasks once started comes from your example to live life. I'm forever grateful, your loving son, Marshall. So in the spirit of that message, I want to say to you, Dad, and to Marshall, thank you for sharing with me and with all of the people in the room your great love of public health. I take a lot of pride in carrying forward not just your name, but your ideals. So thank you. Okay, so enough about them. I've been fortunate to have worked with a really terrific team at the Health Communication Research Laboratory for, as you've heard, 22 years now. And the work that we do is really focused on improving the lives of low-income and minority populations that suffer a disproportionate burden of health problems. And we do that using communication-based strategies. In the last few years, maybe you've heard the term maker. It's become kind of a chic way of describing people who create or handcraft tangible products. I would describe the work of our center as lying somewhere at the intersection of making and science. So we develop solutions and we rigorously evaluate how they work. And if our solutions, communication solutions in our case, are going to make a difference in health disparities, they've got to do at least these three things. They've got to increase the reach of health information into vulnerable populations. They've got to increase the effectiveness of that information for those populations. And most importantly, we've got to be able to use information and technology to help connect people to actual services that can make their lives and their health better. And so all of the work that our center is involved in is aimed at addressing one of these three broad disparity goals. So today what I want to do is share a couple of insights that we've gained from this work, some lessons learned. We know a good deal, actually, about communicating with low-income and vulnerable populations. I'm going to get to that in a few minutes. But the first 2 points I want to make are more fundamental and I think, frankly, more important for working with disadvantaged populations. So lesson one is this, that health is not a primary value. And this is sobering for a lot of us in health professions because we somehow allow ourselves to believe that everybody else cares about reducing risk and promoting health and increasing longevity, that everybody else cares about that as much as we do. And the hard truth is that they don't. And the sooner we can move beyond that to, I think, a more productive view of the role that health plays in people's lives, the better we're going to be able to not just communicate about it and promote it, but ensure that it happens in communities. Raise your hand if you have heard of burpee seeds. Are there some gardeners out there? Excellent. Okay. So this is a famous mail-order seed company. It's now over 150 years old. The son of the founder is a man named David Burpee, and he built it into one of the most successful mail-order companies in the world. And he was interviewed about what made the company so successful, and he had a response that's become really quite famous. Some of you may have heard it before. He said, "I realized early on," and here's the quote, "people don't care about my seeds, they care about their gardens." People don't care about my seeds, they care about their gardens. And as health professionals, we need to spend, I think, less time sort of promoting and pushing our seeds and more time figuring out what it is about people's gardens that matter. And you know who understands this, among others, is virtually every consumer product manufacturer. So you're looking at an ad here from Jeep. Jeep manufactures a transportation appliance. Its fundamental function is to get you from here to here, but they would never in a million years think of selling you a transportation appliance based on that functionality. Instead, Jeep sells you adventure. There are many other manufacturers of transportation appliances, and they'll sell you their version based upon things that you might care about. If you're very interested in safety, Volvo has a nice transportation appliance for you. If you're interested in protecting the earth, then Toyota's Prius might be something that you would consider. Adventure, family security, and love of nature, even if these things are only aspirational, these are the things that people live for. And we call these values. So the first person to kind of study and write about values systematically was a guy named Milton Rokeach in the 1950s. And Rokeach recognized that there are two broad types of values. One type of value he referred to as terminal values. These are kind of the ultimate goal in life. And you can look at this list and see whether maybe some of your terminal values are represented. But what Rokeach found was all across the world, different countries, different cultures, there actually weren't that many different terminal values, maybe 16 of them or so, that captured what people really sought in life. Now, the second type of values that he described, he called instrumental values. You can think of these as kind of how you might characterize yourself or how you might want others to characterize you, the way you conduct your life on a day-to-day basis. And these values, these instrumental values, are connected with the terminal values. So somebody might be ambitious and hardworking because they want to live a comfortable life. Somebody might be dependable and honest because they want to be respected in their profession. So these are values, and I'm not entirely certain of the history here, but for some reason in health promotion we have placed more emphasis on attitudes historically than we have on values. I think the truth is they're probably both important, but it's fair to ask, what might our approaches look like if we paid more attention to values and integrated values more purposefully into the work that we're doing? What would it look like if we focused less on selling health when we're trying to promote health? I'd like to illustrate this with a story that's actually not ours, but this is the best public health story you've never heard before. How many people know what you're looking at there? Well, that's a picture of anyone? Ski jacket, good. I have to remind myself we're in the South here. You've probably never seen one of these. Well, it's puffy and it looks like it. So this is a ski jacket or a parka, a winter coat. But it's not just any winter coat. It is also a life preserver. So we call these in public health and injury prevention float coats because it will do two things. It will keep you warm and it will also save your life if you fall in the water. Now, where would you need a float coat like this? Not in Atlanta, surely, but you would need one if you were in a place that was very cold and had a lot of water, like the Yukon River Delta in Alaska. Alaska has the highest drowning rates in the country, and the Yukon River Delta has the highest drowning rates in Alaska by a wide margin, or at least it had them. And the reason for this makes sense when you get a view of the land, which is spectacular, but you can imagine that when all of this is covered with snow and ice, as it is for much of the year, that one misstep or driving in the wrong place on a snow machine and you could find yourself in a river or a lake or a pond and drown. So we've got these float coats, evidence-based, engineered solutions to prevent drowning. Public health workers march in, and nobody wants to wear them. None of the villagers want to wear the float coats. And they won't wear them because they don't really view drowning as preventable. Their lives, generation after generation, in these small villages on the Delta, tell them that drowning is inevitable. Drowning is part of what happens when you live here. And when you talk to them, it's clear that the pain is not just losing a loved one, but the pain is that you can't often recover the body of that loved one for a proper burial that their culture would dictate for months. And It's not easy. It's difficult work to drag a lake. It's dangerous work. It takes a lot of time. Everyone in the community is affected by it. Everyone in the community participates in doing it. That was part of their pain. And so the public health people met with the local leaders, and they decided on something kind of revolutionary. And they promoted the coats as helping you find the dead bodies of drowning victims. If you wear these coats with their reflective shields and their bright colors, when one of you drowns, you'll be able to recover the body much faster, much easier, less dangerously, less of a burden to the community. And you're not going to drown because it's going to save your life. So, did it work? Yeah, it worked. And over the course of about a decade, drowning rates in this region dropped by threefold to no different than the rate of drowning for the state of Alaska. So what we view as important, prevention, isn't always what's going to be powerful as a motivator to bring about change. Let me skip to a bit of ongoing work that we're doing right now at our center. We're in the midst of a survey among Medicaid beneficiaries in 4 states, one of them here in Georgia, and we're studying life values of these Medicaid beneficiaries, all sorts of different values, personal values, social values, and we're trying to understand what those look like here and how, if at all, they're associated with health and health behaviors. Let me give you a quick example. So here are 8 out of 24 social values that we're assessing in this population. Take a second, just look over them, and ask yourself, if you had to pick one, only one, that was most important to you right now, what would you pick? So here's what the Medicaid beneficiaries said. Let's see how you compare. Number 1, by a very wide margin, and again, this is so you're picking from a list of 24, and we do it systematically, so it's not, there aren't, built-in response biases here. Out of 24 responses, assuring that my family is safe and secure, 37% of people pick that. 9% of people pick a deep connection to my religion. 9%, we were kind of surprised with this, picked I want to keep in good health. And then you drop down to 5%, and here are 4 responses that all got 5%. So one way to think about this is that for every person who says their number 1 social value is to stay in good health, there's at least one other person whose top social value is to live a strong spiritual life, and there are 4 other people who want to keep their family safe and secure. Or put another way, 90% of this population identify something other than health as their top value. So let's take the deep connection to religion. How might we leverage that kind of information in our health communication or health promotion efforts? We actually did a study about this over a decade ago, but it's still, I think, relevant. When we identified the cultural values of a group of African American women who were 40 years old and older in federally qualified health centers in St. Louis, and we would match the sorts of mammography promotion messages that they received to their values. So a woman who whose faith and spirituality was at the core of her values might get a message like this: the Lord has given us a powerful tool to find breast cancer early when it can still be treated effectively. So getting a mammogram together with the power of prayer gives you the best chance to live a long and healthy life in the service of God. So we wouldn't give that message to just anyone, but we were betting that giving that message to someone whose faith really mattered would make a difference, and in fact, it did. We were able to increase the use of mammography by over 2.5-fold among those who got these value-centric messages in addition to a behavioral intervention. Let me jump back to our survey work. Here's another question we asked those Medicaid beneficiaries. What would make your life better? Pick the one thing that would be most important to you right now that would make your life better. Again, take a second, figure out how you would respond to that. Got it? Here are their responses. Very consistent with what we saw in the other one. Taking care of your family, helping your children thrive, making positive changes, getting a better job, managing your money, managing your stress. Health doesn't make the first page. These 5 responses account for over 2/3 of the responses. If we look a little deeper, we find health. It's right there with growing as a person and feeling positive about your life, so it's in good company. But again, not a major driver, at least for this population. And here's what's most interesting, is if we look closer at those who said, the one thing that would make my life better is to live a healthy life, I want to have you take a look at how that varies by the level of stress in these people's lives. So we also administered a short stress scale called the PS4, and we classified people into high stress, moderate stress, and low stress. And so we're looking at those who said, the 8% who said living a healthy life would make my life better. People who had low stress, at lowest end of the scale, many more of them said health is number 1 for me, 14%, about 1 out of every 7. But look at the group that scored highest on this stress scale. Only 5% of them select health as a top priority. I think this is particularly important and relevant, that maybe 1 in 20 people in a high stress situation would view health as something that would improve their lives. And that leads us nicely into our second lesson here. And that is that health is one of many needs and arguably not the most important among vulnerable populations. So if your refrigerator looks like this, if you are in a housing situation that's unstable, if this is the sort of scene that you walk past coming in and out of your neighborhood every day, if you live in fear or at least conscious awareness that somebody in your life might hurt you at any given time, if you send your kids to schools where they've got to walk through police inspection and metal detectors every day, if you don't have enough money to account for essential day-to-day living expenses, let alone unexpected expenses, how important is it going to be for you, really, to get a vaccination or to get a mammogram? So we call these basic needs, and this is classic Maslow's hierarchy of needs, if you're familiar with that work. This is the base of the pyramid. Do people have food? Do they have housing? Are they feeling safe and secure? Do they have enough money for essentials? We've kind of rediscovered these basic needs in the last few years, and we've rebranded them as social needs, I think as a byproduct of our focus on social determinants of health, and we've expanded the list a little bit beyond what Maslow considered. So things like child care and employment, transportation, social isolation. And this is kind of a hot area right now in our field and at the intersection of public health and healthcare. So there have been a lot of good studies published just in the last 2 or 3 years about these basic needs. And I want to just give you a quick sense of what people are finding. So this is some work that actually comes from our group, surveys we've done of some 211 callers. This is a kind of a social services helpline if you're not familiar with 211. And we found that 89% of 211 callers said that it was unlikely or very unlikely that they would have enough money for unexpected expenses in the next 30 days. 70% said they wouldn't have enough money for necessities. And about a quarter of people said, I don't have enough space in my house for the people who live there, and my neighborhood is not safe. Here's another survey, this one from parents at a safety net hospital out in California. So here, these folks indicated, 45% indicated that they were going to run out of food before they had money or food stamps to buy more. Another 44% said they couldn't pay the bills. A third had trouble finding a job, and a lot of them had unstable housing. And here, these are moms at a community health center who were there for well child visits. Unemployment, a major problem. Housing instability, major problem. Child care, food insecurity. And these studies also are remarkably similar in kind of capturing how many of these unmet basic needs people have at any point in time. And so this is just at the moment when they're being surveyed, and it's only responding to questions that we ask people, but roughly somewhere between 2 and 3 unmet basic needs at any moment. So what are the effects of having these unmet basic needs on health and health behavior? So if you're interested in this subject, there's a really nice book that's fairly recent, I'm going to say maybe 4 years old now, that summarizes in a very accessible way the latest science behind this concept. Essentially, the bottom line is that the constant stress of having these unmet needs reduces people's cognitive bandwidth. They're simply unable to pay attention to things that are not of that basic, urgent, social need context. And that translates into short-term thinking and decision-making that we might think of, I don't want to sound judgmental, but poor decision-making, at least from a longer-term perspective. Moreover, this helps us understand some of the pretty serious consequences that are associated with having these unmet basic needs. So mental health outcomes are worse when unmet basic needs are high. Physical health outcomes are worse. Healthcare utilization and costs are higher, and mortality is higher. So unmet basic needs, not a good thing. We'd like to avoid those. I would propose kind of thinking about it in the following way. Having these unmet basic needs causes stress for people. It disrupts their sleep. It has these mental and physical health consequences that we've talked about. And then that constellation of variables really, under those conditions, people can't, they can't act on other things. They're not motivated to do that. They don't have the bandwidth to do it. They don't even remember some of those things. They may not have the time or be able to put forth the effort towards the health outcomes that we might be interested in. And this is one of the reasons, I believe, why so many of our evidence-based interventions don't work very well in these populations. So we march in here at the end with our health-promoting interventions that provide people with maybe motivation, or we try to enhance their ability with some skills, provide them with opportunities, and we just don't get the same results here that we get in other populations. What we think needs to happen is a complementary approach at the same time, which would address those basic needs at the front end. So how can we connect people with resources? How can we help them solve these basic needs problems, provide coping and support and social services so that we can change the trajectory and really kind of increase people's ability and openness to address some of these health problems. So this raises a couple of questions. I think the first one is, can you help people resolve their unmet basic needs? And the answer to that is some strategies work. Those are showing up as green boxes. They're supposed to be pluses. Green is good, red is bad. So here are some things that work and don't work. We know that if we just ask people questions about their basic needs, that doesn't help them solve their basic needs. Probably heightens their anxiety. We also know that if we just give them a resource guide, here's a list of some places in town that can help you. We know that that doesn't help. But there are some things that do look promising. So more purposeful connecting of people with community resources seems to work. Navigating, or what my social work colleagues would refer to as case management, also works. And then social policies, think about raising minimum wage. Those things also work. So if basic needs can be addressed, would that actually improve health? Would that influence health outcomes if we could help people address some of their basic needs? We've got a postdoc who is published a paper about a year ago that addressed this, and we think the results are pretty interesting. So what she did was, in this sample of about 1,000 low-income residents in Missouri, she measured their basic needs and then also provided them with a health referral for whatever health needs they have, and she was looking at about 8 different health referrals. And then she followed them over time. At 1 month, She simply looked at whether or not the problems they had, the basic needs problems they had been resolved. Not very many had. So only 38% of them had resolved the problems that they reported a month ago. 60% had not. And then she looked at whether or not they had contacted the health referral that they had received. And without doing anything, simply having the problem go away, we didn't try to help them address the problem, she found significantly greater responses to health referrals. But the most interesting thing is she then reran the analyses looking only at a subgroup of these participants who received a health navigator to help them access the health referral that they acted on. So now look at the difference. So now, if people are able to resolve their health needs and get some personal assistance within the healthcare system, almost half, 45% of them actually acted on the health referral that they had received, and they were over 2 times as likely to do that. So addressing basic needs with some special attention to the health needs seems to be a winning formula. And at least one of the organizations that has noticed this is the Centers for Medicaid and Medicare Services. As some of you may know, they have made or pledged to make a major investment, $200 million, as a bet, really, on their Accountable Health Communities initiative, where they're going to find out whether helping people address these unmet basic needs, in fact, has benefits in terms of health outcomes, health utilization, and cost. And I think there's a bigger question here, too, about whether healthcare moves into taking over social services that maybe we'll discuss at the end. Okay, so I did say that this was going to be a talk about communication, so there'll be a bit of that here. Let me just quickly try to summarize some of the communication tactics that we have used and found to be effective. You've already heard or seen examples of some of the things we've done with tailored messages and navigators and health referrals. We've done campaigns of different sorts. Here are the kiosks that were mentioned earlier that, in fact, yes, laundromats and libraries were the big winner there. We spent a decade studying stories, personal narratives, and how those can be powerful as behavior change tools. We worked with StoryCorps, which some of you may recognize from NPR, to do other personal narrative work. We've developed animated data visualizations for health policy advocacy in the area of tobacco control. We've studied the effects of health disparity messages on different populations, majority populations, minority populations, journalists. We, and I really mean my wife Charlene here, has developed a health news service for black newspapers in the U.S., an image library, a data dashboard for social needs. So we've done a lot of this making and testing of these, and I want to just summarize for you what I think are the kind of the important takeaways. Some things that consistently seem to yield more positive results. To the extent possible, when you can make information relevant to my life, my situation, my family, get people thinking about themselves, which we call well, I'll get to this in a minute. We think of it as self-reflective processing. That leads to better outcomes. We know from our work with stories and others that while all those letters after our names, the formal credentials, are important, at least to us, that what really matters to people in many instances is lived experience and similarity. Can I identify with you who's providing this information? And trust. And those things all enhance the effectiveness of communication. And then lastly, and this seems so simple, but it's really critical, and that's exposure. I mean, if you can't get information or communication in front of somebody so they actually encounter it, you have zero chance of success. So figuring out how and where exposure takes place in people's lives and kind of meeting people where they live is critically important. Engaging them in a way that they actually experience something not just cognitively but also affectively or emotionally also leads to improved outcomes. Now, there are some reasons why, for those of you who might be interested in why these things work, why these approaches work. First of all, any communication that's engaging and that evokes emotion is more likely to catch and hold people's attention. Anytime we can get people thinking about themselves, what we call self-reflection, you got a fighting chance. You have a fighting chance to change them if you can get them processing things at a very personal level. And then lastly, with some of these stories that are engaging, you actually undermine people's counter-arguing. People buy into a story and they engage with characters, and things that they might otherwise dismiss or say, I'm not sure I agree with that, that kind of goes away. Last lesson learned. I would say and strongly encourage those of you, I know there are a lot of students in the room and also faculty members, to really think about how your work can be informed by people not just from other disciplines, but specifically from disciplines outside the health sciences. And I would submit to you that every really promising idea that we've had came from talking to people who saw the world differently than we did, and being able to make connections that we almost certainly wouldn't have made staying within our own little silo. And I'll just finish with this one example from business and marketing. So students, for sure, you guys have heard of Nike ID. Raise your hand if you've made your own shoes. Don't be shy. Okay, good, a few of you. So the Nike ID site, and now hundreds of others like it, is based on a concept that's called co-creation. And it's the idea that developers and end users are working together to create something that the consumer actually wants, that the end user wants. So some of you may have done things like make your own shoes or other things. What we know about co-creation from the business literature is that it has some measurable effects. People feel like they have a stronger connection to the final product. They're more engaged and dedicated to the brand. They're more satisfied with the product, and they're more likely to share it with others. So how could we take a concept like that and apply it to our work in public health? Well, there's some really low-tech ways. These are some career development magazines that we created with language arts students at a middle school in St. Louis to try to expose them to public health careers. But there are also some high-tech ways that you can think about it as well. We've built an online system called MIO, which stands for Make It Your Own, and allows people to create their own versions of evidence-based small media and client reminders by customizing them with images and messages and in languages that will appeal to the specific groups that they're serving, and they can do that for a number of different health outcomes. So a nice example, I think, of how learning from these other disciplines can give us good ideas for making a difference in public health. These are not all 430 people who've worked with our center over the years, but many of them, at least the ones we could get pictures of. I want to recognize them because this is absolutely a team sport, and we couldn't do it without all these folks. And then lastly, some of the folks who've supported our work institutionally and with funding. Thank you very much. I'd be happy to take questions.
Thank you, Matthew. Matthew's going to take questions. There's a mic in the center of the hall, the walkway, so go up, identify yourself, and go at it.
Thank you. Very good, Matt. I think this reflects efforts that are being made in public health to get where you're heading us. The one thing that seems to have gotten traction, that would seem to do much of what you're advocating, is community-based participatory research. What's your sense of that?
Well, so this last little piece that I described, what marketing people call co-creation, is essentially community-based participatory research rebranded and applied to consumer products, right? What I like about it is that I think one of the ways, and Larry, I would love to hear your reaction to this, but one of the ways that CBPR has struggled is it's pretty intensive, and it's I don't know the extent to which it's been scalable, and there are some advantages of doing some of this through technologies that allow people the ability, in some, for sure, lesser way, but still to have input in the design and creation of solutions that would make sense for them. And so I guess I'm probably not a CBPR purist as much as I really embrace the concepts of input from stakeholders in meaningful ways. And if we can do that through technology solutions, we ought to be.
Matt, thanks for your presentation. You talked about scarcity, and as we think about health disparities, certainly scarcity is a problem, not just for health, for a whole lot of other things. And so in your presentation, you demonstrated or showed that in some cases, the intervention was helping those individuals to meet some basic needs. You didn't talk as much about what the mechanism for that was. I think if in public health we understood better how to help individuals and communities meet their basic needs, then I think you're suggesting we would do better at getting to the issue of health.
Yeah.
And so could you talk a little bit about what the resources actually were in these studies and interventions that allowed these individuals to be able to have their needs met?
Great question. So actually, we've not yet conducted a study, although we're 9 months into one that's into a big study that's doing this. We've not yet conducted a study where we intervened on basic needs. What we've actually done is just observed what happens naturally with basic needs, because people can find help in some instances. So the work that we're currently doing is exactly that. We're actually comparing what outcomes will we get, and we're doing this with smoking cessation, where one arm, actually two arms of this 2x2 factorial design are providing people with a basic needs navigator. Now, what will that navigator do? Basically leverage existing social service resources in communities. Now, that's a limited solution, as probably everybody knows. We've actually studied this. We did a statewide study of the outcomes of social service referrals. So 1,000 people, you get a referral to have somebody help meet your utility bill payment this month. How many of those folks actually get help? And it's not much. If you're looking for food, you got a good chance. Maybe 75% of people are able to get connected with a food pantry. At the other extent, if you're looking for help paying your rent or your mortgage, the local community resources are helpful only about maybe 15% of the time. So overwhelmingly, people, the demand for basic needs help exceeds the resources that communities have to address it. So the fundamental challenge is a structural one, and not necessarily a connecting one. But we think an important step is to be able to connect people with the resources that do exist, because in some cases they don't understand that. Now, one of the risks is, and I see this as healthcare gets involved, is healthcare, folks in healthcare, particularly those who serve vulnerable populations, they're keenly aware that this is a problem, that people's number one health need might be food. The prescription they need might be housing. So they get that. But I suspect that in many cases their motivation is going to be highest to address those problems among really expensive patients, which makes sense from a kind of a business model, but that would leave a lot of other people who still would need assistance. So hopefully that begins to answer your question. Great question. Yes, ma'am.
Thank you for your presentation. It was very insightful. I wanted to ask you, just to go back to Dr. Lean's point, and the way you answered to that question, how do you see the future of these kind of initiatives, since the local help is not very abundant, and we know that it's not easy to solve the problems of everyone, especially when it comes to money problems, housing, food, etc. How do you see the future of these kind of initiatives? Thank you.
Great question. If I had the answer to that, that would be really something. But I'll share a couple of reactions to that. So we had at our equivalent of this speaker series about a month ago, we had the health officer from the state of Minnesota come and speak with us. They've got a big statewide health disparities initiative, and they are always in the top 2 or 3 healthiest states. And he told us that over his 30-year career, the most important public health solution that he'd been a part of was Minnesota's raising the minimum wage to $15 per hour. So I think the optimal solution is to develop sustainable policies that give people, a fighting chance at a livable life. That's not always easy or simple, but I think that's what we ought to be moving towards. It's also clear to me, and I don't know anyone who would disagree with it, that the social service system, as it's currently constructed, is not just underfunded, but it's really, it's fragmented. It's not particularly coordinated. I don't know how efficient it is, and you wonder why it hasn't been, why some industry hasn't sort of moved in and taken it over, perhaps because there's no, they perceive no gain, no financial gain to come of it. But I do wonder if that might be changing. You've got healthcare accounting for, like 20% of the gross domestic product, and if we find out that these basic needs are critically linked to people's health, might you see some people in the health industry taking over the social service function, at least for some of their clients? It wouldn't surprise me if that was in the future. Yes?
Hi. I came in on the tail end of your presentation, but thank you so much for being here. My name is Katilia Harden, and in the state of Georgia, we're making a lot of leeways with understanding that poverty and education, how they kind of coincide with the correlationship of it. So some of the things that my people are doing work with is school-based health centers, and there's a lot of segue taken on with that. So you mentioned the technology part, and so a lot of people are saying, well, hey, let's get more bang for our buck and try the telemedicine. Do you have any kind of insight on that? Because we do see, at least in school-based health center, you have the behavioral health aspect, you have the medical providers that's there, the teachers, the nurse navigators, the dentists in some instances that are there. And so the kids are missing less days in school, they're getting education, the family have access to these resources as well. So what's your take on, if you have a take on school-based healthcare as a resource, and plus how they now are looking into more telemedicine as another resource?
Great question. So I'll respond first about schools broadly. So I've been in St. Louis, Missouri for 24 years, and I don't know if any of you are from St. Louis. You've certainly read about St. Louis in the news in recent years. We have all sorts of challenges with health inequalities. It's one of the most racially segregated cities in the country, and I've been doing health disparities work there for about a quarter of a century. And I'll tell you, this is not based on evidence, it's just based on instinct. To me, the two things that would make the biggest difference to improve disparities are families and education. And if we could get those two things right, and assure that those were very strong, very positive influences, we'd have a whole lot less health disparity to mop up in adulthood. And so, to your question about, can schools play a broader role in assuring the health of students and families, I think we ought to be exploring all sorts of different models where that might work. But you're not going to improve health disparities without making schools and education a really high priority.
So yeah, thank you for your presentation. if I can sort of try to put an efficient sentence on the first part of your presentation, it was sort of like your position of resource scarcity is going to drive your prioritization of values. Is that fair?
Yeah, I'll go with that, sure.
Okay. So,
Unless I don't like what's coming next.
Well, I mean, so it shouldn't. No, well, I'm just saying it shouldn't surprise us, right? When there's an immediate risk to your, an immediate perceived risk to your survival right now, it's going to trump the sort of long-term health risks that you might face in some intermediate timeline.
Sure.
Right, and that's just a fact about human nature. Given that fact, given that that's a resource scarcity issue, right? I'm a little bit perturbed by the focus on bringing the tools of advertising in to treat this, where those tools are particularly driven to reach people who are in resource-rich situations. That strikes me as, you know, it's like the hammer that sees all the things in the world as nails.
Yeah.
So, you know, and on the other side, when you talk about the resources, I mean, you're working in an industry that has a lot of resources, but of course the people that you're seeking to serve are by comparison resource poor, and those resources go through that industry.
Yeah.
Right. So how do you deal with that issue of resource capture on that end, on the one hand, and then how do you deal on the other end with sort of the pernicious worries about using tools that are meant for relatively well-off consumers to help people who aren't in a situation to appreciate those tools?
So, great points, and I'll just have a couple of quick reactions to that. So, there's a bit of a, in my presentation and in my work, what I'm really interested in is eliminating disparities. The tool that we use is not exclusively, but primarily has been communication. So that's where, you know, you might see, you know, some marketing influences along with, you know, these vulnerable population foci. But I would say this, and I hope that especially the students in the room hear this clearly. When I was a public health student at Carolina, there were clear heroes and villains, and at that time, healthcare, medicine was kind of a villain. There are obvious villains. The tobacco industry was a villain. Industry was a villain. All these people, anyone who's in any way involved in something that might compromise health. I've evolved, I think, a bit in how I view that. And rather than see everything in sort of black and white issues, trying to figure out what we can learn from all sorts of other perspectives and disciplines, regardless of whether it's being used to promote health or compromise health. I'll give you a concrete example. I actually almost included this in the talk today. We interviewed 750 food stamps participants a few years ago. And we were just this was more like audience research than health research. We're trying to figure out what sorts of things they did on a daily basis, on a weekly basis, on a monthly basis, what kinds of things they really enjoyed doing. At the top of the list of things they enjoyed doing, scale of 1 to 10, this was like a 9.5. Number 1 out of 30 different activities was listening to music, these food stamps participants. Number 1 on places you go. We had a whole long list of places in the community. Have you gone here in the last month? Number 1 was public parks. 78% of people had gone to a public park near their home in the last month. Now, if you put those two together, people like listening to music and they like going to public parks, you have just described the playbook of the tobacco industry from the 1990s and 2000s when they sponsored the Cool Jazz Festival and all sorts of other neighborhood music festivals in parks to appeal to low-income consumers to use a dangerous product. So we may be 2 or 3 decades late to that party, but better late than never. We ought to be using those sorts of insights and saying, how can we apply those to get health goals met and some of these basic needs met? So I'm not sure if that's entirely answering your question. Maybe we can talk at the reception afterwards, but a few thoughts.
One more question. It's Jeremiah Williams, second year MPH student. I had the pleasure of meeting you not too long ago. But
Good to see you again.
Yep, great presentation. Just a side note, I just listening to you, all the work you guys have done to understand the needs and the values of certain populations, it just screams cultural competence. And I think that's something that's missing across the board. We need to really hone in on that in all areas of society. But just side note.
That's great. Thank you.
But you talked about guiding people in need towards resources as an effective means, a way to address health disparities. Some would argue that at some point you want to guide people, but then pull back and let them be self-sufficient, right? Has your organization done any research on the train-the-trainer method? I don't know if you're familiar with that.
Yeah, sure.
Okay.
Well, so we have not, but I love that idea. I mean, so what we're testing is, we call them basic needs navigators, but basically a person, a live person who can help you to do something that might be unfamiliar to you, that has some insights or some connections. This is, we also think of these people as agents, like you get a real estate agent, because buying and selling a home is a kind of a complicated transaction, and most people don't do it that often. You get a travel agent. Do we even have those anymore? Because it can be complicated to book, travel like a safari to Africa. And so that's not rocket science. Could you have community members who became these sorts of basic needs navigators to help people through? You could, and I think you already do. Some of that happens naturalistically. Could you make that something more formal? I think you could, and it's worth testing. Thanks very much.
So before Matthew leaves, I want to thank him again for giving the 4th annual Kreuter Katz Lecture. We have a small gift in your honor. I think you can take it on the plane.
Okay, all right.
Although it's a little heavy and it doesn't tip. Congratulations. Thank you again. As we wrap up, and we have a reception afterwards, and my words will be few, but I just want to acknowledge that, again, with the support of the Healthcare Georgia Foundation 4 years ago, we established a committee that annually selects the lecturer. Gary mentioned them previously in terms of who is selected, but I'd like the committee to stand up. Larry Green, Ginny Harris, and Linda Kay McGowan, please. These are our committee that select the annual speakers. We really have been truly honored. I mean, everything you've heard today about that's written in the program, you've heard people comment about how we value Marshall and Martha in terms of what they have done and what they continue to do. Martha was the first chair of the board of the School of Public Health, the Institute of Public Health, technically, for Georgia State. Marsh was one of our first faculty members, and the only word to describe Marshall is indefatigable. He would just exhaust us all in terms of his energy and his effectiveness. So they have been longtime friends of the school, and we're excited to announce today that they're continuing their support of the school. They have established the Kreuter Katz Family Scholarship in the school of $1,000, not $100,000, $1,000 annual scholarship that'll be awarded to one of our master students who demonstrates financial need and shows a strong commitment to health equity and community development. So Marshall and Martha, thank you again.